At the outset, I welcome our very distinguished panel on the subject, led by Dr. Giorgio Gandaglia from Milan, Italy, Tobias Maurer. I may be not pronouncing as Italian or European names, from Germany, Fizi van Leeuwen from Leiden University in Netherlands, Christopher from Germany, and similarly, Dr. van der Poel and Sophie Nipper. Just to tell you, Vattikuti Foundation sits at the junction of technology and surgeon education. We very strongly believe technology per se has no value until it's being used appropriately. And we have been wanting to keep surgeons ahead of the game as and when new technologies come. Today's subject, the advances in imaging modalities, restaging methods, and cancer-specific tracers, intraoperative detectors, radio-guided approaches, and PSMA-guided surgery have revolutionized the diagnosis and treatment of prostate cancer. These novel techniques have shown great promise in improving the accuracy of cancer diagnosis, restaging, and detection of lymph node metastases. The use of PSMA-specific tracers and radio-guided approaches in prostate cancer surgery has the potential to reduce the risk of positive surgical margins and to improve the accuracy of cancer detection. Further research and development in these areas are needed to improve the outcome of prostate cancer. I believe so that this webinar would really bring in information from the knowledge creators on this subject, which have been so ably picked up by Dr. Gandaglia, really who's who on the subject. So we are really grateful to them for sparing this time. And we also believe that this is going to play a major role in improving patient outcomes and giving best to the patients with the clinicians we have. With this, I thank you very much once again and hand it over to Dr. Giorgio Gandaglia.
Thank you. And I'd like to sincerely thank the Vattikuti Foundation and Dr. Bhandari for organizing such an interesting webinar, which addresses one of the most advanced topics in urology nowadays, which is the role of molecular imaging and intraoperative imaging to guide the management of our surgical patients affected by prostate cancer. And I'm very happy to be here with you today and to be here with such a panel of great expertise in this area. And that being said, I'd like to invite Tobias Maurer to introduce himself and the first speaker. Thank you very much.
Well, thank you all. Thank you, Giorgio. I think this is a great panel, great experts and great friends, I have to say. And the topic, I think, is a very important one to detect metastases in prostate cancer, especially lymph node metastases. And yeah, I would like to, without much further ado, hand it over to Fais van Leeuwen, who's really a great friend and has done some amazing stuff. Please, Fais.
So thank you, Tobias, and everyone for the kind invitation. I've been assigned the difficult task to open up with all the technical possibilities from an engineering and a chemical perspective. So I'm going to struggle now in the next 10 minutes to provide you lots of information that hopefully comes back in the more applied talks that follow. So what we're trying to address is a clinical need and a need to discriminate disease from healthy tissue. And basically in the surgical field, it's not always obvious which targets or which light bulbs in this sense need to be removed and which ones should stay in. And that can be rather confusing or tiresome even. So the thing that we're trying to achieve with imaging is to just illuminate the odd one out, right? So really light up the tissues that are relevant as targets and that need treatment. And today we focus on nodal metastases, and then you have different routes of targeting these. So it can be either lymph nodes, the sentinel node targeting, which is basically lymphatic drainage, or targeting of PSMA expression. I will come back to that in the end of the talk. What I would like to start with is the technical aspects. And one thing that we find is absolutely critical is the imaging beforehand. So independent if you do sentinel node imaging or PSMA imaging during surgery, the roadmap that nuclear medicine provides is critical for the success of the execution of the surgery. So basically, the surgeon needs to know beforehand, one, if the targets are there, and two, where the targets are located. So to emphasize this, here you see an overview of a study that we did where we had a sentinel node tracer that was radioactive and fluorescent. And we blinded the surgeons for the preoperative imaging. And then we saw that with fluorescence imaging, we could only detect the nodes in half the patients. So it's really, the intraoperative imaging is highly relevant and highly valuable, but the preoperative roadmap is equally critical. Because we're gonna talk about intraoperative imaging all the time, I wanted to have this out of the way. So we need the preoperative imaging. The risk if you don't use that is that you underestimate what you're looking at, right? So if you look at an image, you usually already have an opinion, and especially with technologies like fluorescence, that can be really tricky, and you can get an iceberg-like situation with all the disasters that may follow. So Henk asked me to put in some technical details on optical imaging, on fluorescence imaging. So especially for Henk, I put them in. I won't go through the whole slide, but I think it's important for everyone to realize is that not only the camera settings and properties are critical for the success of fluorescent imaging, but also the dyes that you use, the agents that you use. There are lots of features that can influence the signal, but that can also mess up the signal. So in that sense, for fluorescence, really caution is needed. The rest of the talk, I will focus more on the use of radioactivity. And there we have the concept that the robotic systems as they are now very much mimic the human setup, right? We have a vision in the endoscope, stereoscopic vision. It can do fluorescence imaging that's standardly integrated. And what we now want to do is sort of convert the instrument to sensing devices like your fingertips, but then allowing them to sense molecular features like radioactive tracers. So then we come to the engineering, right? Because when we wanted to do this, there were no such detectors. So we had to design the detector. So we do this in our workshop. And the concept that we have here is that we try to adapt the detectors. You see in your left screen, that's a traditional laparoscopic detector. Try to adapt it to the steerable robotic instruments so you get optimal degrees of freedom. The solution we came up with was a drop-in gamma probe, which has been in the clinic since 2019 and has been successfully used in sentinel node and PSMA applications. And I don't think you will hear the beeping sound now. So that's actually good because there's a really annoying beep in the background. But you can use this radio guidance in combination with fluorescence imaging, as you see here. And the whole probe can be operated by the robotic surgeon sitting in the far right of the OR. What we found is that this probe, the degrees of freedom it provides, so the fact that it can really articulate with a surgical instrument, really improves the detection sensitivity in radio-guided surgery compared to traditional laparoscopic gamma probes. So with that, it suddenly opened the market for robotic procedures. And something that we explored together with Tobias Maurer, also present here, and others, is the use of the drop-in gamma probe for PSMA-guided surgery. So I think there will be more on this topic later. So I won't go into that any further. What I would like to show is that we can even advance the design beyond what we have now. Is the drop-in probe is something you need to pick up and put down. So there's a bit of a delay logistically. A click-on detector is the next step where you can still manipulate the tissue with your grasper and do the imaging. So that's in the preclinical phase, but there's progress to be made here. Ultimately, what we're moving towards is sort of a surgical workflow where we can combine the imaging beforehand with intraoperative gamma tracing, fluorescence imaging if you can, and hopefully ending up with a happy Henk, as you can see here, assuming that a happy surgeon also means a good surgery and a happy patient in that sense. So it's not only engineering, right? So engineering is part of it, but it's also tracer development. So we also need to do some chemistry because the chemistry defines which targets actually light up. If we then look at prostate cancer surgery, we have a number of features here on the slide. The key ones I want to discuss now are the nodal involvement and the primary tumor. So the nodal involvement you can target with PSMA or with sentinel node imaging. The primary tumor is only PSMA. One critical feature that needs to be kept in the back of everyone's mind when you use these type of tracers is the clearance route. So the prostate lies at an intersection between the bladder and the kidney. So it really anything in urine goes through the prostate. So if you have tracers that are renally clear, that can cause a background signal. So if we then look at the two applications, so on the left sentinel node, on the right PSMA. Sentinel node is a local injection. PSMA is an intravenous injection. The targeting of these two types of tracers is very different. The sentinel node targets via lymphatic drainage. It's not tumor specific, but it lights up tumors that are likely to contain metastases. So it can detect very small metastases, at least it's not related to the size of the metastases. The PSMA targets intravenously. It is tumor specific, but it needs larger metastases for it to effectively target. So there's a limit in size to the PSMA application. The most critical aspects herein is that really limits or really influence the signal intensity. So as you see here at the bottom of the slide, in a typical sentinel node procedure, we have about 1,000 counts with a gamma probe. In a typical PSMA procedure, we have about 130 counts with the gamma probe. So going from lymphatic imaging to receptor targeted imaging means you almost get a 10-fold loss in signal intensity. This combined with background signals, etc., really makes the receptor targeted approaches way more difficult compared to the sentinel node. So there's always a misunderstanding that people think, hey, it works with sentinel node, I can do now receptor targeted. Yes, you can, but it's not that trivial. So what we did for the sentinel node is we developed a so-called hybrid tracer where we combine the value of a radioactive tracer that accumulates in lymph nodes with the value of fluorescence guidance. So we can have the whole radio guidance as I showed you with the preoperative imaging, but we can complement it with fluorescence imaging, as you can see here. And you know, based on these results, we also see that there's an interest for such technologies in PSMA targeted surgery. So we recently did a Delphi consensus, and this is one of the questions that we addressed. And then when we asked the urologist what type of guidance modalities they would like, and they basically say either gamma probe or fluorescence or a combination of the two. The other technologies, either they did not have enough knowledge about, so they were quite neutral, or they did not have an interest in. So based on this, we argued that it made sense to also make a hybrid PSMA tracer. So this is some of the work that we did. Again, I won't go through the chemistry, but the main thing that we try to address next to affinity are the pharmacokinetics. So we try to design a tracer that would not end up in the urine and would not contaminate the surgical field. So that's lots of work. At the moment, we're translating this tracer to the clinic, and we used preclinical studies for that. So you see Paolo Dalloglio in the background doing the robotic surgery at Orsi. And this is a trajectory that we're now going through to also get the hybrid approach in the PSMA-guided surgery. So basically extend the radio-guided as is, and as will be presented later on with fluorescence. From a chemical perspective, one thing that we need to keep in mind is the false negatives and the false positives. So do we need sensitivity or do we need specificity? If we want to raise the signal, can we raise the dosing? And maybe it sounds very trivial for most, but it really, in fact, it's not. So if Tobias is doing PSMA targeted surgery, he's using microdosing. If someone else is trying to mimic the same approach with fluorescence guidance, they're using like almost 100-fold or even 1,000-fold higher dose of agent. So that really changes the rules of the game. So from a chemical perspective, I would really urge everyone to think about the dosing that they use and, well, if that can yield false positives or false negatives. So just to round up, as you see, there are lots of aspects to this. I try to cover mostly the technical ones, but it's really a team effort. So we need multiple disciplines to work together. And as a final slide, some acknowledgements. And with that, back to you, Tobias.
Well, thank you, Faiz. I mean, this was really a great overview. I mean, you've done tremendous work and your group on tracer development, on development of detectors. I think this is, of course, like you said, this is the basis, forms now the basis for the next talks. I think also, and this is also something that you highlighted, is very important, the difference between sentinel procedures and background signal, which you don't really have, and the molecular targeted procedures where you do have some background and you need to cope with that. But yeah, I think from this platform, we probably start right in with the clinical presentations. And Giorgio, you want to tell us some about the role of radio-guided surgery, PSMA radio-guided surgery in the primary staging in patients who undergo primary radical prostatectomy.
Thank you very much. And I hope you see my screen.
Working fine.
Great. So a main question from a clinical standpoint is why should we consider intraoperative imaging and robot-assisted radioguided surgery approaches in prostate cancer patients? And well, the reason is that we are still performing too many unnecessary and useless pelvic lymph node dissections. Even if we use the most advanced models developed in patients with prostate cancer, you can see that up to 80% of the procedures are useless. We do not need to perform these lymphadenectomies because we are not retrieving positive lymph nodes. And this is also associated with a substantial risk of side effects. You can see that we can have intraoperative complications such as vascular lesions, pelvic nerve injury, and an extended pelvic lymph node dissection, which is, however, still the gold standard for detecting lymph node metastases and for nodal staging of prostate cancer patients. Well, an extended pelvic lymph node dissection is associated with a substantial risk of complications and of readmission after a radical prostatectomy, even after a minimally invasive robot-assisted radical prostatectomy. So many are advocating for a role of imaging, molecular imaging for nodal staging, and the advantages are that it is a non-invasive tool, It can identify metastatic nodes outside the standard anatomically defined templates, and it can change the management of our patients before surgery. However, if we look at the accuracy of molecular imaging, and we are talking about PSMA PET imaging, we can see that the sensitivity, it is still too low. It is about 40% for lymph node metastases, and the reason is that preoperative PSMA PET CT or PET MRI still miss micrometastatic disease metastases which have a diameter lower than 5 millimeters, and this is based on the intrinsic spatial resolution of this technique. Well, this is scaring if we see that up to 60% of our patients have lymph node metastases when they are PN1 patients, while their lymph node metastases are smaller than this cutoff, the 5 millimeter cutoff. When we look at the radioguided surgery, the first evidence has been actually provided by my co-moderator, Professor Maurer, and he was able to develop a protocol which we tried to replicate in the primary staging setting, where patients initially assessed with gallium PSMA PET CT undergo a PSMA SPECT based on 99 technetium imaging and surgery PSMA. And then this is done the day before surgery, and the day of the surgery, we use an intraoperative gamma probe to detect spots with an increased uptake at the level of the pelvic lymph node stations. And this is our trial. We actually aim at enrolling 100 patients. We currently enrolled 30 patients, and we want to include all patients with intermediate or high-risk prostate cancer who are CN0, M0 at conventional imaging, with a risk of lymph node invasion, which is higher than 5% according to the commonly used nomograms. Here you can see the dose injected in the first 28 patients who underwent this type of surgery, and among those we have pathological data available for 22 patients. Operative time was approximately 200 minutes, and the median number of nodes removed was 22. The length of stay was 5 days, and this was a safe procedure where only one patient experienced a 30-day postoperative complication. We did not observe intraoperative complications. Here you can see the procedure where during surgery, so this is our Da Vinci system, and we use a drop-in gamma probe, which was specifically designed by the group of Dr. Van Leeuwen, and you can see that the probe can be easily used by the robotic surgeon sitting at the console, and it provides, the probe provides actually a visual and a feedback to the surgeon related to the sound count rate, which increases according to the presence of positive spots. The key part of the procedure is to detect intraoperatively positive nodes, so nodes that have a count rate which is at least twice as compared to the background, and the background is typically represented in our series by the abdominal wall. So we start with the count rate at the level of the abdominal wall, and then we move to the pelvic lymph node stations, which were already exposed during the first part of the procedure. And then after we perform our assessment with an intraoperative gamma probe, we proceed with an extended, anatomically defined extended pelvic lymph node dissection. Once the nodes are removed, we perform an ex vivo assessment to double check for the presence of nodal metastases. And here you can see that an enlarged lymph node located in the internal iliac region was dissected free, and then we double check for the presence of an increased count rate outside of the abdominal space. So let me see. Okay, so these are the results of the first 22 patients. You can see that the specificity is high, 100%, with a 100% positive predicted value. However, we have a sensitivity which is both at a per node and a per patient analysis disappointing low. It's 47% when we look at a per region analysis, and when we look at a per patient analysis, it goes up to 80%. And this is mainly related to the difficulties of detecting lymph nodes which are smaller than 3 millimeters using this technique. These results are in line with what has been published in the literature, and there are now series with approximately 15 patients each, 3 series showing that this is a safe and feasible technique associated with high specificity, even if in our series, as well as in the series from our Australian colleagues, the sensitivity is still too low. One of the possible means to improve the accuracy of radioguided surgery is to assess which is the best cutoff defining a positive node. And we performed this analysis. You can see that we compared the sensitivity, specificity, positive and negative predictive values for count ratios which were twice as compared to the background, 3 times as compared to the background, or 4 times compared to the background. And actually this analysis told us that the highest accuracy is observed when the definition of positive nodes at radioguided surgery is based on the presence of spots with a count per second, which is at least 3 times higher compared to the background. And with this, I'd like to end my talk telling you that even if an extended pelvic lymph node dissection still represents the gold standard for nodal staging in prostate cancer patients, imaging, and in particular intraoperative imaging, will play a major role in the future. Robot-assisted PSMA-based radioguided surgery is safe, is feasible, and can allow us to properly identify positive nodes, in particular when we have a single positive spot at the preoperative PSMA PET CT or PET MRI. It is still characterized by a suboptimal sensitivity in CN0, M0 patients when we have micrometastatic disease, and in that case, we should refine our technique to allow us to improve and to identify these patients properly. Thanks for your attention.
Giorgio, thank you for your presentation. I think it's terrific, the study that you're designed and you're doing. If I may, I have a first question. Maybe others have also questions. So you perform a PSMA PET prior to the procedure, then I guess, and then my question would be: have you been able to identify all the positive nodes that were shown on PSMA PET intraoperatively, and probably smaller ones were still missed, right?
Yeah, this is an excellent point. And what we realized is that typically the technique is able to detect positive nodes which were present at preoperative PSMA PET. So radioguided surgery allows you to detect that specific node. The problem is that often you still have other micrometastatic nodes which are in the same anatomical region, or not in the same anatomical region, but let's say in the pelvic nodes, and these nodes are missed both by preoperative PSMA PET, which is something we already knew, but also the fact that you have a strong Havid lesion with a high count rate in the same region of other positive nodes might have an influence on the ability of the gamma probe to detect other nodes which are smaller and which are in the same area.
Okay, Henk, you have a question or comment?
Yeah, thank you, Tobias. Excellent talks. Thanks a lot for that. And Giorgio, my question to you is, what is the sensitivity of detecting nodal metastasis ex vivo in your hands? So you take out the nodes and then you measure on a table. I figure you have less background and it must be much better.
Yeah, it is. And what you've seen is based on a definition which includes both in vivo and ex vivo assessment. when we are working, and I'm really, let's say, in favor of your approach using also fluorescence, because the problem of background noise is there when you use gamma probes, and it also requires experience. During the first cases, the technique was still suboptimal, and we had a learning curve also for this. But I agree with you, combining both in vivo and ex vivo assessments is key to reduce the effect of background noise. And you have it particularly at the level of the bowel. So when we go up to the retroperitoneum, sometimes that is annoying, I would say.
Mahendra?
Yes, thank you very much. I have a weird question that these days there is a lot of talk about tumor cell mobility. Movement, and particularly is the basis for some cutting edge work on faster linear accelerators. Do you feel that that needs to be discounted? In other words, is this a reproducibility of these scans if they are done repeatedly, or tumor cell movement would give you different tumor cell masses in different situations?
I don't expect it, because basically in our protocol, preoperative imaging is done 1 month before or something like this. I don't expect it to change a lot within such a short time period. And in general, for the prostate cancer tumor biology, I don't expect that we should see a change from preoperative imaging to intraoperative imaging. I don't know if other panelists have something else.
Maybe I can add to that. So I think if there's going to be any motility, it's going to be on the cellular level. So it's way below the sensitivity of the technologies that we're using now. So it's going to be single cells. And we're not able to detect that by any means at the moment. So it can be the case, but there's no way of solving the issue in the current setting.
Thank you. I get the answer. Thank you.
Completely agree with you, Faiz. You also wanted to ask or comment something, or
I had a short question for Giorgio. So how did you define the way that you measure the signal to background? Because I know that everyone does it differently. So we're all doing the same procedure, but we're all doing different measurements for signal to background. And I did not show our analysis, but we see that really influences the type of comparisons that you're now doing, right? So if you take your background somewhere else, it completely changes your whole analysis. So why did you select this particular background? Why is this the best way to assess it from your point of view?
Yeah, I agree with you. What happened at the beginning, we tried several spots, and what we realized was that the bowel had a very strong background. So we used the anterior abdominal wall at the level of, let's say, when you drop down the bladder, in order to have something which is not too close to the bladder to avoid for background from urine. You shouldn't be too close to the bowel as well to avoid that kind of noise. So we went there because it's in the same anatomical region, and at the same time, theoretically, could be less affected by other, let's say, physiological uptake of the tracer. I don't know if you have other suggestions. As I said, we had a learning curve, so it's we're all.
No, but I think it's a valid approach, but the whole idea behind the tracing is that it guides the clinical decision making. And if you have a high background signal at a specific nodal location, it will be difficult to decide where the node is. So this is a tricky thing to do, right? So I don't have the answer either. So it's just, but I think this is something we should jointly figure out.
Faiz, that's a valid point, and I think you also addressed it in your Delphi consensus. So we're very, eager to read that paper soon. I think we move on. We heard a lot about radio guidance, but we want to see some images now. And Henk, I think, has some fluorescence for us to show.
So let me first give some disclosure. I think the studies we have been doing so far in the field wouldn't have been possible without the aid of industry and certainly the lab of Vijs and other people working in Leiden. What is interesting to see is that industry takes up also the interest in fluorescence guided surgery, because that's what I want to address now at the moment. And if you compare, for example, the new XI system from Intuitive, it's 10 times more sensitive to ICG than the older was. And that is not necessarily a benefit, as Vijs already highlighted, but it is stressing the fact that we will getting better hardware, and I think we get it soon. So these are the fluorophores that have been extensively used in medical practice and studied also in the field of prostate cancer. And I'm going to address only one of them, SO456, in a later version of, in a later phase of my presentation. So the hardware was already mentioned. It's not only Intuitive, which is new XI camera, which is including near-infrared imaging, but other system handheld and laparoscopic systems are available, even to more extensive spectra of light to be imaged. So we've seen the pictures of Vijs and why use near-infrared, and we haven't discussed that, but I would like the panel to think of that and maybe come up with a question: why are we using infrared imaging? Well, we think we use it because it's less visible in the wide spectrum of light, so it's not bothering the surgeon. And that's important if you're doing a sentinel node procedure, and it has been extensively discussed in prostate cancer. And I know there are pros and cons to the whole concept, but we used fluorescence guidance to do some clinical studies and see if the sentinel node principle in prostate cancer can help us forward and improve outcome. So I'm going to address some clinical data. This is the principle. It's the tracer that Vijs already showed you, non-covalently bound ICG. To this case, these studies, it's nanocolloid. It's now in Europe, at least, nanoscan. And technetium, it allows you to do a SPECT CT scan after intraprostatic injection, and intraoperatively, you can either use the gamma probe shown before or see it under near-infrared imaging. So we did 2 studies because there's basics that haven't been addressed. Where do you need to inject the tracer? And we did 2 relatively small randomized studies, about 60 patients in each arm. The first study compared intratumoral injection, as is shown in 2 injections here on the right, versus 4 injections distributed in the prostate. And basically what we found was that the percentage of patients with positive nodes was much higher if you injected the tracer intratumoral, but you missed some nodal metastases that were derived from non-index lesion tumors. So the conclusion of that study was you have to do both in order to do a proper sentinel node. And the second question, and this hasn't also been addressed, but Vijs was talking about the non-covalently bound ICG to the nanocol and technetium, which is simultaneously injected in 1 injection or in 4 injections in this case in the patient. But you could also do it sequentially. So you can use nanocol bound to technetium, have a radioactive tracer, and then several hours later or several minutes even prior to surgery, you can inject free ICG. And we were interested in a randomized study comparing these 2 approaches. And the interesting thing that what we found was that if you use the right probe, which is bound ICG, you have a higher specificity. So the detection of nodal metastasis seems to be a little bit more specific if you use that hybrid tracer, as we call it. But if you use the combination with free ICG, you find more nodes and you find more positive nodes. So the number of positive nodes removed is higher if you use the ICG. So how does it look? Why do we do it? This is one example. This is the obturator nerve on the left side of the patient. This is the robot-assisted radical prostatectomy. And we go down onto the mesenteric fascia of the mesorectum. And then we look and we see that there is indeed a sentinel node very close to the rectum. We would normally not remove these nodes because they are below the mesorectal fascia. And we removed this case, the node specifically because it was detected. So what are the 2 applications I want to briefly address some clinical data from? The first indication is, can we detect lymph node metastasis more carefully if we go for sentinel node approach? So you can take out a lot of nodes, but then you remove a lot of nodes unnecessarily, as Giorgio already correctly stated. So can sentinel node help there? Well, the positive predictive value of a sentinel node procedure is 94%. Which is even much better than any PSMA PET imaging as we have available at the moment. If you do a nodal detection, you find 37% of cases, patients that still have nodal metastasis, even when their PSMA PET scan is negative. Another approach I'm going to show you some data on is the combination of the sentinel node procedure using fluorescence in the hybrid tracer to complement extended lymph node dissection, because 14% of the sentinel nodes are generally found outside the template of the extended lymph node dissection. Going back to the first question, the sentinel nodes to detect nodal metastasis. In this study, we compared our data from the National Cancer Institute to a peripheral hospital data that has the same radiotherapist. And the difference between the two groups, which are balanced, is that in one center, only prostate-only radiotherapy was given. In our center, we do a sentinel node when there is an increased risk of lymph node metastasis. And when these patients have a positive sentinel node, we do not only irradiate the prostate, but we also do radiotherapy to the whole pelvic area, adding ADT in both arms. So these are the radiological recurrence-free survival curves, which are a hazard ratio of 0.47. The approach using sentinel node was much better with respect to radiological progression, and this by avoiding unnecessary whole pelvic radiotherapy in 63% of patients. So the other approach, as I mentioned, is can sentinel node complement an extended lymph node dissection? For that, we did a retrospective analysis of all the patients that were included in sentinel node studies, combining it with extended lymph node dissection, 2 patients that had only an extended lymph node dissection. And here there is a small but significant benefit if you add sentinel nodes to the extended lymph node dissection. So interesting in that specific population that was recently studied by Matteo Droghetti was the fact that in particular patients with positive nodes outside the extended lymph node template detected by sentinel node had a clinical recurrence-free survival benefit. So what's happening next? We saw the PSMA data, and in particular, I think for nodal metastasis, the PRO-PSMA study, of which I show data here, was much better than any clinical imaging we had so far. So maybe PSMA can help us to detect not only by radioactivity, but also by fluorescence, the presence of nodal metastasis. So for that, we were so happy to collaborate with On-Target Laboratory that provided this OTL78, which is a PSMA targeting DUPA-based ligand, and with the fluorophore in the near-infrared spectrum of light, SO456, as I mentioned earlier, and these are some data in mice. Now, the study we did was more of a dose-finding exercise. So these were the 3 doses that we explored in clinical practice in 18 patients, and we used the Da Vinci robotic system joined with the Medtronic-based VisionSense imaging. And just to show an example, this is not on a lymph node, but this is the imaging we have. This is the regular Da Vinci system, and here on the bottom of the right side of the slide, you see the VisionSense imaging. This is a tumor in the prostate. It appeared that it was very close to the edge of the prostate, so we decided to remove additional fat, which was covering the base of the seminal vesicles. And we sequentially imaged that as well. And then you can see the VisionSense image again, suggesting at least that there is a positive surgical margin on that site. So certainly this is a small population, but we did look at lymph nodes as well. That's the topic of today. And we removed 80 lymph node packages in this small study, of which 7 had positive nodal metastasis. 4 of those, so 57% of these, we were able to detect intraoperatively. This is in vivo. And we have to say, and this was also claimed already by Giorgio, that nodal metastases smaller than 3 millimeters are very hard to detect, and we were not able to detect it. But if you use the same imaging system ex vivo, and you get 289 lymph nodes imaged in the pathology situation, And basically, in the correct dose cohort, where we downscaled the dose and waited 24 hours before surgery, we found all the nodal metastases being positive on fluorescent imaging. So the fluorescent signal is there. It's just that we need more accurate systems, I think, to pick the signal up. So where do we stand at the moment? And this is one of my last slides. I think it has been mentioned before. CT scan imaging may be only valuable if you have enlarged nodes. PSMA PET scan really added to that the much smaller nodes that we can detect. I think if we go for fluorescent tracers, it may have the benefits to be used intraoperatively, which is very interesting. And if you go for radio-based tracers, I think the size of the nodal metastasis that you can detect is even smaller, although I put a question mark here because, as Giorgio said, even the smaller nodal metastasis, radio tracers are missing. But what can be very helpful there if you add the sentinel node? Because the sentinel node procedure is not sensitive to the size of the metastasis, and it's going to be able to detect even nodal metastases that are not even detectable by microscopy. Well, the rest of the slides, I think most of you have seen already in Fai's presentation. I'm very much looking forward to the combined dual tracer, as Fai's already showed. It's going to be radioactive as well as fluorescent, and we hope to combine the benefits of both worlds into a clinical study at the end of the year. So what else are we doing? We're not only interested in tumor, we're also interested in reducing complications. And you can do that by better tracing which lymph nodes are relevant and which lymph nodes, when removed, only cause complications. And for that, we did some multicolor fluorescence imaging. This is in a PIC situation where the leg of the PIC was injected and the periurethral gland of the PIC. And there you can see where these tracks actually merge. And these are the first clinical data in which we have been doing it in men as well during prostatectomy, showing that, yes, indeed, if you use multicolor fluorophores, you're able to distinguish those lymph nodes from the leg from those lymph nodes from the prostate as well. Well, all this work we were not able to do all the work without the help of all these people. And I would thank everybody for participating, and I'm happy to address any questions if there are.
Thank you, Henk, and it was an extremely interesting presentation. We as surgeons basically want to see something. I mean, we like probes, it's true, but at the same time, they are difficult, not difficult to use, but they still require some, let's say, handling. And when you see something, you're happy to remove it and to tell your patient, okay, we basically removed all what we could see. So my question is, do you think the future is actually here, and how can we move forward? Which kind of studies do you need to prove the superiority of this approach and to replace an anatomically defined pelvic lymph node dissection?
Yeah, that's an excellent question, Giorgio. I think the first answer we need is whether lymph node dissection at all is impacting on patient survival. I think that's crucial. Then again, if we do those studies, and they are ongoing, and some of them, Tobias, you may help us there, the PREDICT study is almost finished, I think. It's difficult to get the right endpoints, but if you do not do the correct lymph node staging or lymph node dissection, you may not find the answer to help there. So I think if we're doing those studies, yes or no lymph node dissection in patients with prostate cancer, it would be very helpful, I think, to add these imaging modalities.
And do you think the role for this type of technology and technique is actually more evident when we talk about, and here I'm talking about systemic tracer administration, where we talk about recurrences, as Tobias Maurer showed in his pioneer work? Or do you still believe that we can aim at maximizing local disease control with intraoperative imaging, even when the prostate is in place?
I think it's going to be both. It's going to be both, Giorgio. What we find now, we also participate in a study. 50% of patients do not get a lymph node dissection, and many of them recur, and we use the imaging as proposed by Tobias. I'm not really sure that the fluorescence is going to be very helpful there. because the nodal metastases are in general very small, and you will not be able to detect them with fluorescence. But for the primary prostatectomy, for the surgical margin positivity prevention, I think fluorescence is going to be very helpful. I'm sure of that.
Yeah, that's Henk. You really nicely showed, the margin assessment during that one image. I think that's really, really good. Just to answer quickly your question, predict we scale up to over 3,000 patients now. Jonas Eckert is also in the discussion here, participating. So we still need to wait for that, for the lymph node value of lymph node dissection.
Thank you. And now we can move to a talk on intraoperative PSMA PET for the detection of nodal metastases by Christopher Darr. And I think they have one of the first experiences with this technique of use of intraoperative PET detectors during prostate cancer surgery. Please, Christopher, the floor is yours.
Yeah, thank you for the kind invitation and the opportunity to talk about the intraoperative PSMA PET for detection of lymph node metastases. So for local staging, the European guidelines recommend at least a cross-sectional abdominal pelvic imaging, and in high-risk prostate cancer patients also a bone scan. But for the detection of lymph node metastases, either the CT or MRI performs poorly, with a slightly better sensitivity for the MRI, but still there's a lack of detection rates. So just to complete it, for the surgery, there is evidence that extended pelvic lymph node dissection should be performed in high-risk prostate cancer patients, and roughly 5 to 10% of newly diagnosed prostate cancer patients have synchronous suspected pelvic lymph node metastases, at least on conventional imaging with an CN1 M0 stage. To outline whether local treatment or systemic treatment has an effect on overall survival, there's a National Cancer Database analysis with roughly 3,000 patients, and they compared the local therapy versus the systemic therapy alone. And here we see a huge benefit for the local therapy with or without androgen deprivation therapy. And there's a 70% survival benefit when we are using the local therapy in this population. I think the results of the PRO-PSMA study are well outlined already through my colleagues, and I want to highlight that PSMA PET-CT is most appropriate in the end staging, but small lymph node metastases under the spatial resolution of about 5 millimeter may still be missed using the conventional PSMA PET-CT. So when we argue if PSMA PET can improve surgery, we can certainly say that regarding preoperative staging, PSMA PET-CT is a more sensitive imaging and causes more cases classified as a CN1 state. And for the intraoperative PSMA PET-CT, we know that beta rays from superficial tumor tissue can distinguish tumor tissue from healthy tissue, and consequently intraoperative examination of the resection margins may be possible and is analyzed in several centers. But we so far don't know if there's an adequate signal which can be detected after several half-lives. And in particular, is this also possible for micrometastasis, where conventional PSMA PET-CT has its known shortcomings. So we did so far 10 patients with our one-stop shop protocol. So the patients received the trace injection, either 68 gallium PSMA or 18 fluor PSMA on the day of surgery, underwent the conventional PSMA PET-CT scan to exclude distant metastases, and then the patient is transferred to the OR for mostly robot-assisted radical prostatectomy and lymph node dissection, and all the specimens that were resected are retrieved immediately and imaged in the micro PET-CT. And after this, the specimens are sent for histology for further assessment. So, as I already told, we have so far 10 high-risk prostate cancer patients with a median age of 65 years. And the median time from tracer injection varied, but it's roughly 310 minutes up to 400 minutes for both tracers. And interestingly, the activity concentrations in the specimens varied according to the injected activity at baseline, but the median activity for gallium was 1.0 kilobecquerel per milliliter and roughly 8 kilobecquerel per milliliter for 18 fluor. All index lesions which were seen on preoperative MRI were detected on conventional PSMA PET-CT and also using the intraoperative micro PET-CT. Here I would like to demonstrate representative results using 18F PSMA in a 55-year-old patient. We have a PT3A, no lymph node infiltration and a positive resection margin. And here you can pretty good see the tumor focus on the ventral side, pointing out a positive resection margin. And this was also in accordance with histopathology. And the next case demonstrates a 64-year-old patient. Here we used 68 gallium PSMA. Here also we saw a positive resection margin at the apex, outlined with the orange arrow. But there was also a lymph node metastasis, and this lymph node metastasis was not seen in conventional PSMA PET-CT, but could be clearly outlined in the micro PET-CT. And interestingly, the activity at time of imaging for the lymph node specimens was 0.29 kilobecquerel per milliliter. So half-lives were 6.6 post-injection. And at the beginning, I questioned whether micrometastasis can also be made visible in the micro PET-CT. And in this case, we have a 69-year-old patient, again with 68 gallium. And here there was a closed surgical margin on the dorsal left side of the prostate, which was indicated in the micro PET-CT. But more interestingly, there was also some prostate cancer infiltration of the vas deferens, and histopathology revealed the micrometastasis. And this could also be visualized in the micro PET-CT. In image D, I demonstrated the image of histopathology, and left to it, there's the image of the micro PET-CT. So what we can state so far is, in the current setting, high-risk prostate cancer patients are at higher risk for local recurrence and lymph node metastasis. And obviously, multimodal therapy is of great importance in this patient population. Intraoperative specimen PET-CT is, at least in those 10 patients, feasible, but challenging in a single injection protocol, because there's a lot of organization to do to get the patient from the PET to the OR within a reliable half-life time. There are good results, even of small structures below 2 millimeters, and there's a gap we have to still work on. So we need to optimize the intraoperative PSMA PET-CT in terms of timing, which could be made better using an intraoperative injection. And obviously, there are also prospective trials needed for further evaluation of oncological outcome. So the question is a patient-tailored resection or intraoperative frozen sectioning based on intraoperative high-resolution PET-CT possible? I hope that we find out the answer in the future. And another possible way we could use this new imaging technique could be a sentinel node excision and field expansion in case of positive lymph nodes to reduce morbidity of extended pelvic lymph node dissection. So I would like to close that prospective studies are certainly warranted to evaluate sensitivity, specificity, and biochemical recurrence rates. Thank you for your attention, and I wait for your questions.
Thank you and congratulations. I see Henk with a question, so please, Henk.
Yeah, thank you, Christopher. Nice work. Certainly it is elaborative, and I'm not sure about the system, but it will probably be available. The practical question I have is the thing that we were struggling with was the fact that most of these PSMA tracers are secreted in the urine. So what's the optimal timing, and wasn't urine pollution of your tissue after removal a problem?
So in our setting, or in our study protocol, after retrieval, we rinsed the prostate twice and then analyzed it. And so far, we don't have a contamination of the urine. We also analyzed urine from the indwelling catheter in the micro-PET-CT, and there we did not see any activity or radioactive activity. So far, I don't believe that there's a contamination, but just to be sure, we rinse and wash the prostate specimen.
And if I may, one further, what's the radiation exposure of the OR personnel if you use this tracer? Is that an issue?
Yeah, so we analyzed it in the first patients, and for gallium, I can tell that the scrub nurse gets most of the radiation, certainly, depending on where the scrub nurse or the first assistant is positioned. And so far with 68 gallium, there's an examination of at median 6 microsievert per surgery. So depending on the regular projection rules, in Germany at least, we could perform roughly 100 procedure per person each year. But I have to note that 18F is a little higher, so there the exposure is much higher. Maybe a short note. So we hope to move forward to the intraoperative injection to reduce the total administered activity at all, and there it might be less, but so far we have to have an eye on the exposure.
Tobias, please.
So yeah, Christopher, thank you for your nice presentation. Really, it's amazing work as well. I mean, the fluorescence that we just saw is really nice to see detect intraoperatively while you're dissecting really the tissue. The drawback here is you have to remove, obviously, the tissue to scan it. However, you get idea about tumor volume and how close, or how you can scroll through the whole prostate, for example, how close the margin is. So I think it's worthwhile really to pursue both procedures, and I think, yeah, it's just amazing how this field evolves, I have to say.
Yeah, that's absolutely true. Yeah, thank you.
Yeah, we have another question, Faj.
Yeah, Christopher, thanks for the nice presentation. Just a small question. So how do you scale the images? Because you saw the signal every time nicely in the area where you want it to be. But for example, if you have the prostate, there's always basal PSMA expression. So the whole prostate should contain tracer. So which reference points did you use to scale the images? I think it's a very similar question to the one I asked Giorgio, right? So what's the standard to which you represent the data? Can you say something on that?
Yeah, so far we don't have a standard to where to put the threshold for analyzing. In the images I showed, the threshold was 0 to 80% using kilobecquerel per milliliter, and we are eager to analyze using an iterated algorithm if we can perform like a standard using the SUV to make a better threshold. The problem in our protocol is that we have a huge variety of activity levels at analyzing or imaging the specimens, so it's hard to make one standard for analyzement. But what we saw so far is that there's not a huge background of the prostate. So we were trying to analyze the signal to background ratio And this was pretty hard because in the prostate, at least at these half-life times, there was no real measurable background signal.
Okay, thank you.
I have one last short question. Is it increasing substantially your operative time? I mean, does it take long to get the images and to change your management also?
So for this study, we do not change the surgery at all. It's just feasibility if the whole setup is working out. And the imaging duration is roughly 10 to 12 minutes. So we normally resect the prostate, retrieve it from the abdomen, and then the OR is going further with the lymph node dissection, and then parallelly we analyze the prostate specimen. So there's not much of a delay, but certainly a few minutes there is.
Thank you. And with this, we move to the last talk of today. Sophie Knipler will present us the results of the role of PSMA radioguided surgery in the recurrent setting. Please.
Yeah, thank you very much for the kind invitation. I'm happy to present a little bit our results on the PSMA radioguided surgery now in the recurrent setting. So as we are all aware, depending on the extent of the disease, there are different options on how to treat prostate cancer. And while localized and metastatic, I think we quite know what to do. In the local regional metastases, it's really a bit difficult on the decision what to do. And one of the options may be the salvage lymph node dissection, ideally to prevent maybe local complications, but even prolong treatment-free survival, and eventually maybe even have a permanent cure. The problem with that is that the high-level evidence for the oncological value already in the primary setting, but also specifically in the salvage setting, is completely lacking. So even if we know that, why are we still doing it? Well, there has been quite an extensive part of retrospective data, but also some prospective data that tells us that maybe it does help. So this is the thumb trial, which many of you I'm sure will know, and it shows that in this phase 2 trial, it shows that actually patients who have been treated locally or metastatic directed, that actually they have a longer time to ADT necessity. And it was specifically in the patients that were who were treated for local recurrence, for a nodal recurrence of the metastases, which you can see here in this forest plot. So actually, if we want to do that, then what is the challenge? And you can maybe see this MRI image here now, and I'm telling you it's a patient who has a recurrence with a PSA recurrence after prostatectomy. In this MRI, even as maybe radiologist, it'll be difficult to find something, but if we add PSMA to it, then of course everybody will be able to find this little small lymph nodes atypically located. So in this situation, if it's atypically located, the PSMA radioguided surgery may be the help of how to find this little lesion intraoperatively. I will show you a little video for this, and hopefully the sound will be hearable as well. Well, not so much. Ah, it does. No. So here you can see intraoperatively on an open surgery, the gamma probe coming in. And that's the part where the metastasis is located. And this is on the ex vivo. Hope you can hear a little bit. At least you can see that this is working. Oh, sorry. Okay, so if we now saw a little bit how that works, is the PSMA radioguided surgery really better than conventional salvage surgery. We did a small retrospective analysis of roughly 50 patients who were treated with either the conventional approach prior to the PSMA, before we had the PSMA radio-guided surgery. And actually, which is most compelling, that some of the patients who were treated conventionally actually didn't have, or we didn't find the lymph node metastasis, which has also been shown then in the PSA decline after the surgery, which was better in the PSMA radio-guided surgery, which lets us assume that at least the short-term PSA responses were significantly in favor of the PSMA radio-guided surgery. What can we expect of the PSMA radio-guided surgery? So this is the cohort of Tobias, mostly having operated it in Munich and in Hamburg, and it's roughly 350 patients who had a BCR after radical prostatectomy and who were treated with PSMA radio-guided surgery. And most of the patients had only one lesion in PSMA PET imaging prior to surgery, and mostly also in pelvic localization. And what you can see on the plot on the right side is that most of the patients actually really responded very well after the surgery. Also, most of the patients we were able to remove metastatic lesions, so more than 90% of patients actually did have prostate cancer lesion in the histopathology report. How is the biochemical recurrence-free survival? So it seems like not to be as good as you would hope, but actually the therapy-free survival is quite compelling, with almost 3 or like 2.5 years after the surgery. And the most important predictive factors for that would be patients who had a low PSA prior to surgery, who had a low number of positive lesions, and ideally a pelvic localization of lesions. I just want to quickly state that the post-operative, or like the intraoperative complications, were quite low. So only about 5% of patients had important complications during surgery, while most of the patients, if they they experienced complications, were more of lymphocytes or lymphedema after the surgery. What is new? New is a little bit it's a little bit longer now, but the first robotic surgery for PSMA radio guidance was done in May 2018, and the team in Amsterdam, they actually already performed a feasibility study that showed that actually it is feasible to do it also with a drop-in gamma probe, and works out really fine. So the outlook on how to select ideally patients that would benefit of PSMA radio-guided surgery may be one-time biomarkers. There is a small study we did on CTC, so circulating tumor cells, and we had the impression that patients who were CTC positive would probably be the ones who are not benefiting of the surgery. But there are certainly a lot of other studies ongoing to actually find out a little bit more about the salvage lymph node dissection and also the biomarkers on long term, which patients may benefit the most. So to conclude a little bit, we absolutely have to say that salvage surgery, and specifically PSMA radio-guided surgery, is still experimental. We should, if we want to do it, really be very careful about the patient selection. And ideally, if we consider it, it should be based, of course, on novel imaging modalities, with maybe this type of idea to start with a local salvage treatment, and then maybe plus or minus add radiotherapy or ADT before in the long term needing systemic therapy. And with that, thank you for the attention, and I'm happy to answer any questions.
Thank you, Sophie, and congratulations to you and Tobias for this work, which was actually of pivotal importance to move forward to where we are now in the field of intraoperative detection of nodal metastases for prostate cancer patients. So it was really inspiring all of us. And my question is, as you said, how should we select our patients? In our center, we have actually a longer-term experience with salvage lymphadenectomies, both in open and robot-assisted surgery. And now the numbers are decreasing because we see that this is a surgery where at the end the patient should be properly selected, otherwise the risk of early recurrence is there. So I know that you have data supporting the oncological safety of this procedure. How do you select your patient, practically speaking? Let's say if you see a patient with another recurrence tomorrow, what will be the parameter to tell him, okay, you should receive this kind of surgery?
Well, I think it's the most important is really the number of localization, the number of lesions and the localization. And I think patients who have an extended retroperitoneal lymph node recurrence, of course, they won't be the ones benefiting the most. It should be discussed individually. I don't know, Tobias, it's something we always wanted to do, to have some kind of model to be able to find a cutoff. But I think with most of the prostate cancer patients, it's difficult to say, okay, you are really have a cutoff until here it's good and until there it's not good. So I think it's always an individual approach. And well, as I said, the best is single localization in the pelvic with a low PSA below 1, maybe that's I think the optimal patient.
Thank you.
Yes, you agree, or?
I totally agree, Sophie, but what I want to add is what we really always need to focus on is the life expectancy of the patient, not to do such a surgery in very old patients who would not see the benefit. And also maybe biomarkers will tell us in the future if we have systemic disease.
Yeah, Sophie, we were basically discussing with Giorgio, but also with Christopher, how to get the signal to background. So how to define which node is positive and what is background. And in your setting, which is predominantly open surgery, is there a specific trick that you use? I know you do a lot of ex vivo validation, which is easier in the open surgery setting, but is there something we can learn from that, you think?
Tobias, I think I'll give this question directly to you.
So basically, I mean, background is an issue in vivo, yes, but still, I think a few millimeters is really important. How the distance is between the positive node and your detector, and most of the lesions you can actually find if you very slowly move your gamma probe around and here for the subtle differences in background. But then again, most of the time, I think those salvage lymph node dissections should be a clean template. So I do the measurements outside. And if I don't find it outside, then I go back in to see where I might have missed the node.
Okay, so it's a combination of the ex vivo, which is easier when you're doing open because they're easily taken out, but also slow movements. Because I think that's every now and then that's an issue with the robot, right? So people tend to move faster than the crystal can detect the signal. So there's a delay.
It's easier ex vivo measurements, obviously. Yes, you're totally correct. But also with the robotics, when you remove the tissue, you can measure right away. The bedside assistant can do the measurements ex vivo.
Okay, thank you.
And you always go for a template lymphadenectomy. You don't do a lumpectomy, right?
Yes, at least the side. I mean, we have a prospective study, the PROST1 study, evaluating if we only see lymph nodes on PSMA PET on one side, do we need to do a bilateral? And those patients who agree are randomized in between unilateral and bilateral lymph node dissection. But unilateral is always the template, yes. Henk, I think you're waiting now a long time.
Yeah, Tobias, I have two questions if time allows, but the first one is addressed a little bit by Giorgio as well, because I think what we see, and you have more experience, so you may confirm this, is it's mostly nodal recurrence after a salvage lymph node dissection. So the template is crucial. Would it be possible to do some sort of sentinel node of a nodal recurrence, for example? Is that technically feasible? Because then you run ahead and get those microscopic nodes that you do not detect with any method at the moment.
Oh, that's a great question, Henk. I think this is really not so easy because, I mean, you would need to have a tracer which is distributing very fast. So basically ICG, uncoupled ICG, and you inject it around the nodes. and then intraoperatively see the lymphatic flow. That's interesting. It's an interesting concept. I've never thought about it.
Yeah, I think it's very easy to do. I mean, it may get messy if it leaks, but if it doesn't, it may be helpful. And the other thing is it's more an oncological one. What we see happening in the studies now in oligometastasis disease, as you showed, and Sophie as well, is the combination with systemic therapy. So what's the basic thinking behind that? Do we have to do systemic therapy first and then do the nodal dissection, or do we have to combine it? What's your view on that?
Well, my personal view.
Well, that's not only to you, Tobias, but also to Sophia.
I'm sorry.
It was her presentation.
Well, the good thing is that no one knows the answer to that. So it's, I think, well, I mean, in terms of radiotherapy, there is often the combination with ADT. So apparently there is some sort of benefit of that. The idea, I think, behind the surgery is to kind of prolong the time where we do not give any systemic therapy. And if we're talking about patients with a slow progressing disease, which should be ideally those we pick for the surgery, then maybe we're not missing out if we're waiting for them to receive systemic treatment. But if patients may be benefiting if they receive the treatment as soon as possible, the systemic one, I think it's difficult to answer. We hope not, otherwise you should be giving everybody everything. So yeah. I don't know, Tobias, you want to?
Yeah, that's what happened in metastasized disease. That they gave everybody everything as much as possible.
Yes.
Yeah.
So.
Okay, thank you very much. And I don't see questions from the audience. So I think
I will become an audience, and I have two questions. Anyone from panel can answer. One of them is, should I consider that data supports that robotic lymph gland dissection is non-inferior to open surgery?
yeah, I think everyone agrees on this. No, I mean, we are a little bit biased because we are robotic surgeons, and younger generations now are, let's say, big fans of robotic surgery. So I think everyone in the future will say that it is even superior because you see better and you can reach anatomical sites which are actually more difficult to dissect by open surgery. But I think maybe Tobias and Henk have a better experience with me compared to me with open surgery and can answer to this question.
The second question I have, which again, you can go back to the first if there is any additional information, what is the current data on trade-off between number of nodes removed and lymph node related complications?
Okay, we know that, let's say, I don't know if someone else wants to answer. Henk, maybe you've been.
Yeah, my comment to that, I think it's a relevant point. It's a relevant question. So it depends on where you go for, if you do a lymph node dissection primarily, is that diagnosis or is it treatment? The guidelines say it's diagnosis rather than treatment. And if you continue that line, you should go for sentinel nodes, which is equally strong in diagnostics, but far less complications. So your point is well taken. I think we are removing too many nodes and given complications to too many people.
Thank you. And if there are any questions, panel would like to say anything, but whenever you would indicate, I would like to take this opportunity to personally thank all of you before we pull the curtain down on this webinar. I mean, it's a masterclass, which was just so great and informative for me. I'm sure it would be for our fellows and the participants. Anyone would like to say anything about how we could have better handled the subject or anything else missing out? Because we are looking for state-of-art knowledge, and that's why we try to get to the best people who have the published track record on the subject.
Well, I think what we saw today here is a lot of novel developments in tracer, in hardware, in detector technology, is really on the edge of moving into the clinics and moving into the routine, and also some more things are to come. So I think it's very, very interesting what's happening in this field, and it's just, yeah, it's just really nice to be watching and also to be part of it. So I think we can expect more from that.
Completely agree, and I'd like to thank personally all of you for participating to this masterclass, and the Vattikuti Foundation and Dr. Bhandari for organizing it, obviously.
Thank you. I take this opportunity to thank each one of you on my own behalf and on the behalf of the foundation, particularly Dr. Tobias from University of Hamburg, Germany, and Giorgio Gandaglia from San Raffaele, Milan, for steering this wonderful panel and putting it together. I really enjoyed Levon's presentation from Leiden University, which was really speaking of how in deep they are producing their own work and drilling deep on the subject. Christopher Darr did a great job from Essen, Germany. Poel from the Cancer Institute in Amsterdam, and of course, Sophie Nipper from Martini Clinic, Hamburg. It was wonderful knowing you guys, and maybe in a few weeks, we'll meet again at Milan during EAU. And Vattikuti Foundation doesn't believe in doing standalone activities, and I'll keep a track of the literature and what is happening. Maybe in next couple of years, I'll bring the panel back to have an update on what the knowledge is taking the direction. Thank you very much.